both presenters, my dear friends and brothers, Christine and Weil, they partly touched to my subject. The important thing is not only the success or the technique that we perform, but also the complications that we may encounter during the performance of PNL, and also their diversity, and how can we evaluate and manage them. We know that PNL was a breakthrough. It was able to treat large, hard, and infected stones, obstruction-related stones, shock wave utility failures, and also stones related with anatomic variations. One-stage procedure and stone-free rates is the highest among all the options that we perform now. But despite all these successful outcomes, we know that it is an invasive procedure, and there may be some certain and severe complications that should be kept in mind. We know that definition and stratification of these complications, there is no still consensus on how to exactly define complications and how to stratify them by severity up to now. Also, evidence-based guidelines, including EAU and AUA guidelines, in the prevention and treatment of these complications in a standardized manner are still lacking. Here you see the overall complications of the PNL, and among them you see 83% complications can be encountered, but of all the complications, bleeding requiring intervention is the most, let's say, fearful one for the operating surgeons. When we evaluate the complications, again, here you see injury to the collecting system and extravasation during the procedure, bleeding, injury to the adjacent organs, namely colon and the other organs neighbor to the kidneys, and also some medical complications, infection, sepsis, fluid overload, or hypernatremia can be encountered. When we evaluate these complications with respect to the Clavian classifications, here you see we may encounter from grade 1 to grade 5. That means mortality can occur, but we know the severe complications, including mortality, are really rare, particularly in experienced hands. It's a nice study summarizing the complications in the light of Clavian grading system, single center experience, 16 years, and here you see 826 cases of PNL in around 700 cases, and majority of the complications here you see are not so severe, and here you see grade 3A complications, including bleeding, were among the fearful ones. Again here, grade 2 complications, leakage, transfusion, and pneumonia, and grade 3A, renal hemorrhage requiring angioembolization, postoperative stent placement, and pneumothorax retention due to the blood clots can be encountered. Case studies and important patients have been evaluated, and the significant bleeding was encountered in around 8% of the cases. Blood transfusion was needed around 6% of the cases, and here you see in around 80% of the cases there was no complication, but majority of the complications were again in Clavian classification type 2 and grade 3A complications. A couple of studies here summarizing with different number of cases. Here you see the complications, and transfusion is around, here is 11% at most, and hemorrhage requiring intervention again 1.4%. The colonic injury, pleural injury, and extravasation are also acceptable and not too high. Bleeding is the most important one, and all urologists, they have the fear of these complications just from the beginning, as we all very well know. Bleeding can occur during every step of the procedure, including the access part, tract dilation, stone disintegration, and also in the postoperative period. But we know this complication is most commonly encountered during the peritoneal access part of the procedure. Is it possible to predict the likelihood of and the severity of the bleeding-related PNL procedure? Some studies did attempt to evaluate the factors that are predictive enough for significant perioperative blood loss and need to blood transfusion. Multiple attempts at initial percutaneous renal access for PNL significantly seem to increase the risk of bleeding. Here is a study published in 2004, and the authors did evaluate the factors in a multivariate analysis, and they were able to show that prolonged operation time, method of access guidance, tract dilation, multiple tracts, size of the tract, renal parenchymal thickness, and associated problems were the factors significantly predictive for the likelihood of bleeding. Here you see the size is very important. As the size go up, we know that the invasiveness of the procedure and the injury that we induce in the kidney will also go up. And miniaturization is on our agenda now. And when you compare 11 French ultra mini PNL sheet with a standard one, you will easily see the difference between their size and the injury that they possibly induce in the kidney. Christian, my dear friend, he really touched this study. We performed this study with the European Guidelines Group, and in the end, we evaluated tract size and its impact on the risk of bleeding, severity of bleeding, and in the end, we were able to show that stonebury rays were comparable in patients with renal stones treated with mini PNL and standard PNL. Smaller tracts tended to be associated with significantly lower blood loss. That means tract size matters. And on the other hand, in this study, variables that influence hemorrhage were evaluated by one of our colleagues from Turkey, Burak Turna, and here you see 193 PNLs, which may influence the bleeding, and the average hematocrit decrease, here you see the value. Calcium stones, single tracts, balloon dilators, and smaller stones were a little bit lower incidence of hemorrhage, but on the other hand, stone type, number of tracts, method of dilation, diabetes, and stone surface area were the predictive factors in the multivariate analysis. Here in another study, Dr. El Naz and his co-workers, they evaluated again the risk factors for extensive hemorrhage, a huge number of PNL procedures. Here you see severe bleeding were encountered in around 1% of the cases, and associated morbidity include perineal hematoma, and also bleeding could be controlled with superselective embolization in around 93% of the cases. Significant risk factors in this study stated was the upper tract stones, calcial puncture, solitary kidney, second stones, multiple punctures, but most importantly, they stated that experience of the surgeon was also very important. In this study, again, only stone size. You see highly variable data for prediction is available in the published literature. Only stone size in this study were found to be predictive enough, and around 1.5% of the cases did require angiography and embolization for bleeding control. And in 22 patients, successful embolization was done. To summarize, we may say that among all the publications that I evaluated, at least in the literature, among the predictive factors, stone size, puncture site, puncture number, and surgeon's experience were the predictive factors in the majority of these publications. Is it possible to prevent or at least limit the risk of bleeding? Yes. A very well-planned patient selection is very important. Bleeding diatheses should inevitably be searched. If needed, procedure could be performed after platelet infusion, and also anticoagulant agents like aspirin and the other agents need to be canceled or stopped prior to the procedures after counseling to the internal department. Again, there are some preventive measures. Access to the collecting systems along a line extending from the infundibulum to the infundibulum to the fornix in a direct way is posteriorly oriented calyx is the major approach from our side to limit the extent of bleeding. This approach will allow a direct egress to the majority of the renal collecting system, and it will let us to avoid the hypervascular regions to be passed and have the bleeding. Percutaneous renal access directly into the renal pelvis should be avoided, and during this procedure, if we attempt to do that, we will have the risk of injury to the major arteries that have close proximity to the renal pelvic area, and it will be too complicated for us. On the other hand, we have some preventive measures. Here you see, once created, the tract should only be dilated up to the peripheral aspect of the collecting system, not going to the further ahead, as well showed us during the complications or tips and tricks. If dilation proceeds too far medially, perforation of the pelvis, renal pelvis can occur with concomitant laceration of the hilar vessels. The method of dilation has been reported to influence the bleeding, and less hemorrhage has been found to occur when balloon dilation has been used during the procedure. Parenchymal bleeding can be diminished by keeping the working sheet in the collecting system during the whole procedure, and by avoiding excessive torquing of the rigid instruments, not to increase the bleeding, the extent of the bleeding. To avoid extensive angulation, if needed, a flexible nephroscope could be used, not to have the torque or, let's say, to increase the rate of bleeding. When bleeding occurs during the access or tract dilation process, advancement of the nephrostomy sheet usually acts as a tamponade to the bleeding, allowing us to continue the procedure. Working in a clear field is very important. That's why we need to remove the blood clots. That's mandatory to avoid further additional injuries during the procedure. Intraoperative bleeding may also be secondary to the over advancement of the sheet, again, as well, my dear friends showed, into the parenchyma, and we need to reposition of the sheet that will solve the problem. If heavy bleeding continues despite the repositioning of the excess sheet or precludes adequate visibility, temporary interruption of the procedure and tamponade of the tract with a nephrostomy tube could be recommended. If the bleeding is controlled and the patient is hemodynamically stable, then we may go further, restart. But in any other case, we need to stop the procedure, abandon, and reschedule it. Effective coagulation is a temperature-dependent, and hyperthermia is a major risk factor. That's why irrigation fluids need to be at room temperature prior to the procedure. And also, for transfusions more than 2 units, we need to check the calcium levels of the serum, and then this should be really closely monitored. Bleeding may occur during any stage of PNL, but acute hemorrhage due to injury, great vessels, or main vessels is really very uncommon. Most incidents of great vessels or main vessels injury occur during initial percutaneous access. Great vessel injury is best avoided by the use of a systematic approach to the percutaneous renal access. Bleeding with initial percutaneous access and tract dilation is often venous in nature and may arise from the percutaneous tract, renal capsule, or parenchyma itself. Minor to moderate bleeding can often be controlled by tamponade with a balloon dilator or K-tamponade catheter. Placement of a larger nephrostomy tube, judicious intravenous hydration, or the intravenous administration of mannitol can also be helpful to us. With refinement of the techniques, increasing experience, and with the use of, let's say, delicate equipment, the overall transmission rate for PNL has fallen significantly from around 7% in early series to around 2%. Significant delayed renal hemorrhage requiring intervention is also rare and occurs in less than 2% of the cases. Of course, bleeding is not the only complication of PNL that we may encounter. We may also see other complications. Here you see inability to access to into the renal collecting system, kinking of the guide wire during the dilation step, bleeding during dilation, and bleeding after the procedure can be encountered, and we need to identify them, diagnose them on time, and do whatever needed. Perforation of the renal pelvis or the ureter is very important. Then nephrostomy, ureteral drainage until the cessation of leakage will be important. Hemothorax we may have, then effective drainage with chest tube, thoracoscopy, and aspiration will be needed. Colonic perforation is important, and while my dear friend also touched to this complication, early detection is very crucial, and bad smelling, gouty aspiration. We need to differentiate air from liquid, and immediately we need to place a JJ stent to renal pelvis and ureter for an effective urinary drainage, and we will place a catheter into the colonic lumen. Duodenal perforation is really very rare. Injury to the spleen, injury to the liver, also very rare. Infection is very important, and we need to apply supportive treatment, antibiotic management, but preoperative evaluation of the case, urine culture, and the preparation of the case also in the beginning is very important. Fluid overload could be encountered, and we need to observe, monitor the patient very well, and when needed, we need to apply furosemide and mannitol during the procedure. Detachment of the nephrostomy tube could be encountered, and we need to insert a new tube, and also in we may encounter or deal with hypermobile kidney, and either a direct access to the middle pole will be advantageous. So to summarize, what are the critical points? We need to have a detailed knowledge on the renal anatomy. That's utmost importance. That means we need to have enough experience, if possible, detailed information about anatomy of the involved kidney prior to the CT evaluation is certainly needed, not only for the kidney, but also for the adjacent organs, particularly for the colonic, let's say, position will be evaluated. Renal arterial system and the branches of the renal artery could be evaluated by angiography if needed. Routine biochemistry, radiologic evaluation, and urine analysis is very important. Confirmation of a sterile urine is a must. Due to the possible bleeding during or after the procedure, we need to reserve blood in our patients, and also calyceal and arterial anatomy of the kidney should be properly evaluated. We need to have all the necessary equipments in our OR just beneath to the operating table, and to use them whenever needed, ready to use all the equipments, including the flexible ureteroscope, whenever needed. We need to use radiologic systems and also sonography in order to skip from one of them to the other. If we have any difficulty to puncture the kidney, to get an access to the kidney, then we may stop fluoroscopic imaging, then come back to the sonographic imaging. That means we and the young generation that are being trained now, they need to have sonographic experience to puncture the kidney. Renal anatomy is very important. We need to know its location and its, let's say, proximity to each other, angles, and also the adjacent organs. Calyceal anatomy is very important, and this may differ from one patient to the other. We need to evaluate the calyceal anatomy by retrograde evaluation just in the beginning. If we have any suspicion, any problem coming from the, say, sonography or CT evaluation. And also renal anatomy, vascular anatomy, we know it very well. Main renal arteries, their segmental distribution, Broadwell line, and that's why, as Christian told us, a perfect puncture through the papilla direct into the calyx, the relevant calyx, in a direct alignment up to the stone will be very important. So, best clinical practice, improved patient outcomes will come from individual clinical expertise, patient values and expectations, and best clinical evidence that we have available. Depending on that, my dear friend Paleoster, he defined the PSA of stones. That means personalized stone approach. In the past, we operated all the patients, but not focusing on the let's say, very important parts. But today we have a lot of options, and all these options for stone treatment have their advantages and disadvantages. And for that reason, we need to evaluate the patient-related factors, stone-related factors, anatomy-related factors, and then decide about the type of the procedure that we will use. If it is the Pcnl, then we need to evaluate all the factors that I mentioned. And to sum up, this is my last slide, the experienced surgeon is not the one who knows well how to go further, but is the one who knows at what stage of the procedure, stop it, to finish it, and then to reschedule it. Thank you very much for your attention. And I apologize from all of you. I beg your pardon. I need to leave now. And if there is any question, I'm sure Wael and Christian will reply them. Sorry for that. I need to leave. Thanks a lot.